Okay, welcome back. The feedback I got was I was too soft-spoken, so I'm going to kick it up a notch this time. Welcome. Yeah, let's talk about antibiotics. I was asked to discuss updates in the world of antibiotics. That's the theme of the morning. Not much to add from Dr. Lewis, but I will try. Yeah, still no disclosures. Nobody made me any spicy offers during the last hour. And we mentioned before pallergy. We're going to come back to this in just a moment because I think antibiotic allergies are a big opportunity for antibiotic stewardship. So, yep, as before, there will be off-label use of antibiotics. I'll call that out. The objectives are listed here. You should know how to select common antibiotics in use for outpatient, especially for skin and soft tissue and upper respiratory. And we'll talk about appropriate use of antibiotics for the prevention of infection, especially people with implantable joints, prosthetic joints. This is a huge area of confusion. And we'll talk about penicillin allergy and what to do there. Antibiotics, it is a problem. And the way that we use antibiotics in this country, as we've talked about, highly fraught. We know that there is approximately one prescription for antibiotics for every American, just about. That's usually in the outpatient setting, but time after time when we look at appropriateness, it's roughly a coin toss whether we get it right. The rights that Dr. Lewis talked about, is it the right drug for the right indication at the right duration? Roughly 50% of the time we American doctors do that correctly. So that's a huge problem, and you can see this paper here where this was looked at in more detail, almost 4,000 cases. In about half the cases, when someone got an antibiotic, they shouldn't have gotten anything. These are usually viral respiratory infections where the prescriber knew full well that it wasn't going to work, but the patient wanted an antibiotic. That prescriber was busy, and they gave in and wrote for the script. There are other reasons that this can happen as well. This is not equal, as Dr. Lewis said. We are special. Top left is best. Left coast is best coast, and top left, I think we are actually better than average when it comes to the prescription of antibiotics. Nationally, our per capita prescription rate is actually lowest in Alaska, state of Washington very close thereafter. There's about one prescription for every 2 Alaskans, whereas in West Virginia, it's the reverse. There's almost 2 prescriptions for everyone who lives there. Why is that? I don't know. I think there's probably a variety of reasons why that could be. I think we should replace the battery. It's not just the way I'm pointing it. I think it's the battery is gone. Oh, we'll keep going. But if somebody has a 2 AAAs Kodak brand, you're welcome to bring those up. Here we go. The map I'm showing you on the left is, anybody? This is a prescription per capita rate. Anybody recognize what that might be? Another class of medicine you may have heard of called narcotics. So the narcotic prescription rate and the antibiotic prescription rates are actually pretty similar. So the point of that last slide was to say that the way we use antibiotics is similar to the way we use narcotics. I think there's cultural differences. I think there may be all kinds of practice patterns, comorbidities, obesity, smoking. There's probably a bunch of things that drive this. And thank you. And no doubt, opportunities for us to try to figure out why those differences exist to attack this inequitability. Having said so, we're better than average here in Pacific Northwest. Can we continue this? Let's talk about this with some examples. Example number 1, skin and soft tissue. I like to break skin and soft tissue into the 2 big fat groups. I was discussing this with one of our participants who works in corrections medicine a few minutes ago. Number 1, cellulitis, and I would define cellulitis as you got a red limb, usually a lower extremity, but doesn't have to be. But there's no pus. There's no purulent focus. This is almost always caused by beta strep, especially group A strep, also group C or group G, sometimes group B, all the alphabet soup of strep, and sometimes Staph aureus, yes, but when it comes to pus, now we're thinking Staph aureus, Right? Now, this can sometimes be group A strep. The Latin name for group A strep is strep pyogenes, meaning the pus maker, but usually we can think of this as being Staph aureus, either methicillin sensitive or methicillin resistant. I'm going to hold it exactly like this. Okay, so how should we cover in the first group, cellulitis, where there is no pus? And the answer is, the theory was, going into this particular study, it's usually strep. Let's treat for strep. And as we talked about in the previous hour, when you want to kill strep, you want to use a beta-lactam. Penicillin, amoxicillin, cephalexin, cefa anything should go after strep. And that's what they did in this paper. 179 patients who had clinical cellulitis. There was usually nothing positive from a blood culture. They just said, I'm going to hunch that it's probably a strep. Hard to culture it because there was no pus to culture. But they took a leap of faith and they treated those patients with a beta-lactam antibiotic. And then they followed them clinically, and they also did something we never do clinically, which was to do a serology, acute and convalescent anti-strep serology, not part of our normal practice. Almost all of these patients got better, and many of them actually did demonstrate a conversion of their convalescent serology. So the point is, this is cellulitis, it almost always is strep, and beta-lactams, that's what's good for breakfast, lunch, and dinner for these patients. We'll go to this. If you have your finger on the keyboard, I'll just say next. It'll be faster, because this, unfortunately, is not working. Thank you so much. Next slide, please. Not all skin and soft tissue infection is staph. Next, please. Okay, so this is what it looks like if you are non-purulent. We don't say not pussy because you can't write that word in the chart. It looks like something else. But non-purulent, usually these patients get, as you can see, a penicillin or a cephalosporin. Can you use clindamycin for these cases? Yes, you can. What we have in my city is 30% resistance in group A strep to clindamycin. 30%. That's really bad, and that happens because of the crisis with opioid addiction and a clade or a group of these organisms that's spreading very readily in that population. Having said so, that's news for 2020 up to 2022. We used to be able to rely heavily on clindamycin. For your patients who are truly pen-allergic, Clinda, I think, could be a good option here. Beware of rising issues of resistance. Next, please. Thanks. So, having said so, how do you prevent this from coming back? And just like we talked about recurrent urinary infection before, now we're talking about recurrent skin and soft tissue. You know those patients. You see them, you treat them, they get better, then they come back. And again, and again. Typically, there will be lymphedema. It could be someone living with lymphatic stripping after breast cancer surgery. It could be someone who's just dealing with obesity. Whatever the issue, usually it's poor lymphatic return. That's the biggest risk factor. I always look between their toes. I try to treat them for tinea pedis, get them into a new pair of shoes. You know these patients, they're called men. They need new shoes. Just get them into the new shoes, and that can help to reduce the burden of fungal infection, which lets the strep come in. Having said so, if you've tried these maneuvers, yes, you can give them penicillin prophylaxis at a crazy low dose of twice a day. Penicillin VK, you would never treat an active infection this way, but for prevention, this has been studied, and even with its short half-life, it works. Cuts the risk of recurrence by half, hazard ratio 50%. The number needed to treat is about 5. So if you have 5 patients with recurrent cellulitis, you prophylax all of them, one of them will probably benefit this way. Having said so, that benefit goes away after we stop the treatment with that medication, so it's not perfect. Let's do the next, please. Penicillin, worth considering in recurrent cases. Treat their diabetes, treat their venous stasis, treat their tinea, but something to consider. And then what if we go from cellulitis to the purulent family, which you see here? This is Staph aureus, as we've talked about, and I think everyone's very familiar with this. What does IND stand for? Yeah, it means I did it. Yes, incise and drain. You have to incise and drain these patients. Is there a benefit to antibiotics beyond that? Well, yes. Certainly if there's a substantial surrounding cellulitis, which is defined as more than 5 centimeters, you're supposed to get out your tape measure and decide whether that surrounding redness is more than 5, then it's pretty well accepted that we should mop up with a bit of antibiotic. By itself, that won't do it. In combination with IND, it can do. And so this big controversy has come up recently. What about giving antibiotics to people with less surrounding cellulitis? Is there benefit to antibiotics in addition to IND, even for uncomplicated abscess? Where I was raised that is not the way, and thus these two papers that came out not long ago that really shook that assumption up for some of us. A double-blinded randomized controlled trial of uncomplicated abscess. All of them were drained, because that is the standard of care, and then they either got trimsulfa or placebo for a week. This is working fine now, by the way. Thank you, guys. So 12% better outcomes in those who got trimsulfa, both by per protocol and modified intention to treat. Antibiotics plus IND performed a bit better than IND alone. Okay, that's in an adult population. I would say IND is still the gold standard and what we reach for. So how do we adjudicate this? 12% improvement. Should they all get trimsulfa? What I've come to in my own, I'm humble and I learn things about infections and antibiotics every day. It's why I do this as my career. I feel better about prescribing antibiotics if I was on the fence. So I think if I have a truly uncomplicated abscess, I will drain those patients and I'll try not to give them antibiotics. But if I can't decide, it's not 5 centimeters, but it's 3.5 centimeters, the patient is sick, they're complicated, there's some factor that makes me nervous, give them the sulfa and feel good about that. Don't go to bed guilty. You're a doctor. Go to bed feeling proud of what you did. And you can say there's evidence to say that in this particular case, I may have done a service to my patient. Having said so, I really wanted to raise the question about, this is a talk on new antibiotics. Remember, this family of antibiotics is here, FDA approved, for skin and soft tissue infections. These are the lipoglycopeptides. There are two. One is dalbavancin, one is eridavancin. As you can see from the structure, this is basically vancomycin, but they've stuck a fatty acid onto the end. What does that do? It prolongs the half-life of that medication. So that instead of vanco, which has wonderful gram-positive spectrum, but is not a very good bactericidal killer, and you have to dose it frequently, you have to monitor the dose, you worry about toxicity, vancomycin stinks. We all hate using it, right? What these drugs do is to mimic that same spectrum, but they're just much more convenient to dose. Instead of dosing every 12 hours, it's dosed once a week. So an incredibly long half-life, a single dose, and for most uncomplicated skin and soft tissue, that's it, one and done. And the clinical evidence, according to the FDA, is that it is non-inferior to vanco, and it certainly is easier to use. And that's why they cost so much money, and that's why we're not using them. The people who make this stuff have made this decision that that's what they're going to charge, and so at least at my hospital, we consider these to be very precious medications, that we have a formal approval process before we ever use it because, well, it costs an arm and a leg, literally. But maybe in certain cases that helps. The way we're doing it at my hospital is not for the routine use of skin and soft tissue infections, but for skin and soft tissue infections or totally off-label for skeletal infections, osteomyelitis, deep abscesses in people who just will not engage in traditional care, right? They're going to leave when they want to leave. They will not necessarily take oral antibiotics. They're living with addiction, and we worry that they're going to come back again and again. In those cases, we have used this, and that's been a successful process. So that's our current process, and maybe at the end, if there are those who have used these medications or are considering them, I'd love to hear how they may have been helpful in your practice. But know that that is an option that's available for you. This is what we're doing for Staph aureus in my city, and I think this is probably similar to what you may be seeing here, but I don't know that for sure. Again, we really need that local antibiogram. So at both Harborview and UW, where I work, between a third and a half of all Staph aureus is MRSA, and then among the MRSA isolates, these are the susceptibility rates. Generally speaking, if you're looking for something PO, it's going to be either doxy or trimsulfa. And most of your patients will be able to take one, if not both of those medicines. There are some people who can't. They just can't. They're deathly allergic to sulfa, and doxy burned a hole in their esophagus, and they won't do it again. I mean, once in a while, you can't do these, and you may end up on something like linezolid, but that's very exceptional. We are so fortunate to have this kind of resistance profile that is there. What is not on the menu, levofloxacin, it just is not reliable in MRSA infections, unfortunately. So having said so, we're talking about MRSA in the skin. What if we switch now to respiratory infections? And I'm going to start with MRSA. If you're admitting a patient to hospital, you're following them onto the inpatient side for pneumonia, you're scared. I mean, we have seen patients die of pneumonia. It's a deadly disease, and so we want to take it seriously. So I get this question a lot. These patients who are admitted with severe pneumonia in my hospital usually get vancomycin, and the question is, should they? Is that something that can be part of routine practice? And the answer is, trust your nose, not the way it smells, but what's in the swab of the nose, right? So let's start with community-acquired pneumonia, and then we'll move to hospital-acquired pneumonia. In CAP, community-acquired pneumonia, hopefully most of your CAP patients can be outpatient, but if you need to admit them, please consider these data that I show here. This is a retrospective series, but it's almost 90,000 patients, so it's pretty big. They looked at patients admitted to hospital nationwide for community-acquired pneumonia. More than a third of them got vancomycin at some point during their course, and they analyzed these cases. Was that necessary? Well, of those 30%, only 2% actually had MRSA, so that was a big overuse of vancomycin, right? Number two, the adjusted odds ratio for patients who got vanco versus didn't. You can see all of those effects. This gets back to what Dr. Lewis was talking about. It's chemotherapy. There are these unanticipated reverberations and side effects when we do this. Patients were more likely to die. They were more likely to have an acute kidney injury. They were more likely to have C. diff. They were more likely to get vancomycin-resistant enterococcus. They were more likely to have a gram-negative infection. It was just a big bowl of bad for those patients who got vancomycin. And again, the great majority actually did not need this. So we really shouldn't cover them for the MRSA. That's the bottom line. These findings, which are robust to multiple methods of analysis, contribute to a growing body of evidence that raises questions about the widespread empirical use of vanco in patients with CAP. The same is true for hospital-acquired pneumonia. Boy, if you get pneumonia in the hospital, at least the way I was trained, you've got to worry about MRSA. MRSA is everywhere. It's in our hospitals. The hospitals are filthy. The patient probably has MRSA. That may be true in your context. I would be surprised. I think our hospital infection prevention techniques in modern America, they're not perfect, but they're really good. I think hand hygiene has revolutionized everything we do with MRSA. I do see MRSA in my hospital because the patients bring it in, but it's very uncommon for people to acquire it in the hospital. And so here's something that I think backs up that concept. Retrospective series, almost 300 patients. They all had hospital-acquired pneumonia. None of them had a culture that would demonstrate what this was by bronchoscopy or blood culture. But they all got treated with vanco because they were all worried about MRSA. And most of them were also treated for Pseudomonas. Anyway, the majority were de-escalated off of, were not de-escalated, but some were de-escalated. And there was no difference whether they turned off the vanco or continued it. In fact, the patients who continued on vanco were a little bit more likely to die, kind of what we were talking about before. So it's a very suggestive issue. The impression of this paper, no harm in stopping MRSA coverage. You would actually have less time in the ICU and less time in the hospital if you stop vanco. What am I talking about for the nose? Whether it's community-acquired, whether it's hospital-acquired, if you have chosen to start vancomycin, let's say your patient is deathly ill and you just don't want to miss MRSA. Let's say they have a personal history of this. Let's say the resident who was on last night started it. You're trying to decide what to do. Check the nose. If we swab the nostrils of these patients, the nares, send that to the lab, there's a very, very reliable negative predictive value for MRSA. I'll say that again. If your nose is not colonized with MRSA, it's extremely unlikely that your lungs are as well. The reverse is not true, by the way. Plenty of people run around colonized in the nose. It's not in their lungs. But if you have a negative result, I think you'll see here that that negative predictive value, more than 95%, that's pretty good. That's not 100%. Somebody's got to be in that 2%, right? Maybe that's someone who is living with addiction, who has a previous MRSA culture. They have certain epidemiological risk factors. You are worried about it. Continue the vanco. But 98 times out of 100, you can probably trust that negative culture. The nose knows. And the reverse is not necessarily true. If they're colonized, please get a deep specimen, a high-quality sputum, to inform whether this has in fact descended from nose to lungs. By the way, that data I was showing you was for pulmonary infections, but thank you to our Veterans Administration who have looked back at big data, very large numbers of patients, and been able to say, can we actually extrapolate this to other body compartments, such as bloodstream infections, intra-abdominal infections, wound infections. The negative predictive value for most of these, again, extremely, extremely good. So it's a wonderful thing to be able to look in the nose and decide what's happening elsewhere in the body. It's kind of a small miracle. Why does this happen? I don't know. Staph aureus really likes the anterior nares. We breathe, right? So it's got good gas exchange. It likes the hair, right? It likes the surface area of our hairs of our nostrils. There's something about the mucin of our nose that it feasts on. I don't know, but it loves it here. You can find MRSA elsewhere in the body, but the nose is a great sentinel, well, canary in the coal mine of what may be happening elsewhere. And thankfully, Dr. Lewis already shared these slides, so I will not belabor with you, but they are here for your reference. Patients who are being treated for community-acquired pneumonia, if they have no comorbidities, you're not worried for MRSA or Pseudomonas, we treat them with Amox for 5 days, as he described. And if they can't get that, then doxycycline or, heaven help you, azithromycin you could do. If they're sick and they have other comorbidities, then we would typically add clav on top of the Amox to broaden its anti-anaerobic spectrum, although it's usually overkill. And we would then add, in addition, atypical coverage with the macrolide. But we do not usually need atypical coverage for most of our patients. That's the bottom line. And for patients who are admitted to hospital, if they're not deathly ill, they're not in ICU, then it just depends. It depends on whether we think they've had MRSA before or not, whether they've had Pseudomonas before, whether you believe the culture data from your own local antibiogram. And that's where these guidelines come from. So I think for outpatient, it's very syndromic. For inpatient, it very much depends on that individual risk factor for bad bugs and previous antibiotic exposure in those patients. But the bottom line here is that we would add MRSA coverage until we can actually rule out the presence of MRSA if patients are severely ill and sent to the ICU. It's never wrong to start Vanco. It's usually right to stop it. And I think we can all feel good about that process. Okay. So I'm going to talk about rhinosinusitis. We talked about deathly serious respiratory infections. Let's deal with what you're much more likely to see in everyday practice, which is, of course, acute rhinosinusitis. And rhinosinusitis, it's almost always viral, and although we think of this as always being COVID-19, that's not so. There has always been colds, and there always will be, human coronaviruses and others. Having said so, the trick is that if it's almost always viral, that means that only a small percentage is actually bacterial. And yet your patient, I predict, will ask you for, antibiotics. And so you have to figure out how to walk that narrow pathway. We don't know, because of diagnostic uncertainty, as Dr. Lewis said, we don't really usually know what we are treating when we see these patients. We have a huge opportunity for rapid molecular diagnostics. At the moment, it's too expensive, and it's not usually available. That's a huge problem for antimicrobial stewardship and for the patient's confidence in what we tell them when we're counseling them. I'll give you some coaching tips which may be of help to you. But the bottom line is that if your patient has had symptoms for less than 10 days, very unlikely to be bacterial. The reality is, even in viral rhinosinusitis, the average number of days of symptoms is probably 21. We used to say that after a week, they're going to be better. If it's a cold, if it's more than a week, they're going to really need antibiotics. That's wrong. So much of what I learned in med school was wrong. That's an example. We know that if it's rhinovirus, you know the virus, that patient may feel sick for at least 2 weeks and often as long as 3 weeks. And we need to counsel our patients to expect this. And I'll give you an idea of how to do this. I like this meta-analysis from the Lancet where they felt that the number needed to treat to benefit one patient with antibiotics was probably 15. If you treat 15 patients in a day with antibiotics for URI, you've helped one of them. The other 14, you've not helped, and you may have harmed. It's a very humbling situation. Again, because we, in ID and public health, have failed you in primary care. We have not given you the ability to do this testing. Testing for COVID-19 has changed the dialogue around this. I think early on in the pandemic, everyone was very comfortable with the idea of PCR to decide whether or not it's a viral infection. Well, that same technology exists for every other flippin' respiratory virus. Why don't we do that? And I think it's for a variety of reasons with the failure of our infrastructure in medical technology, but there's no reason technologically that we shouldn't be able to do this. So, when you are counseling your patient, I think it's great to understand whether they have COVID-19. That's important for prognostics, for public health, and for treatment. And if it's not, then you can say, okay, thank you for coming in. Glad it's not COVID-19. That's okay. There's other bad viruses going around right now. And you can look at your local county dashboard to figure out the positivity rate of COVID-19 among all patients being tested. Right now in my county, Seattle-King County, I think it's something like 1 in 10 or 1 in 12 who actually has a positive test. The rest have other viruses. And you can always say this. There's a bad virus running around. You don't know what that virus is, but it's true. So you can always say that. Thank goodness I did not have to prescribe you antibiotics. You know, when you came in the room, I was worried that I would have to do that. And I'm ready to give you antibiotics if you need it. But I'm glad I don't have to, because until you quit smoking, we're going to have to keep going back to this issue. And I want to keep them potent and useful to you in the future. So that yeast infection you had last time, you're not going to have to deal with that. Remember the C. diff you had to deal with in your grandmother? I'm not going to give you that either. You can stay on your oral contraceptives. I'm not going to mess up with that either. You can go on spring break. I'm not going to give you photosensitivity with these antibiotics. You're good. We just need to treat you aggressively and symptomatically. You got to stop smoking. I almost won't treat smokers with antibiotics. I'm not quite there yet, but they've got to stop or they just won't work. And so we should be skillful in how to counsel and support our patients as they quit. I would schedule the anti-inflammatories, and you should have your own tear sheet for patient information, but don't wait to feel better. Just let's do at least 3 days of acetaminophen and ibuprofen to see if we can get them to feel better. I am a fan of Afrin spray, oxymetazoline. I like that. It gives the patient something to do. It improves their symptoms. And the concerns for rhinitis medicamentosa, the addiction to it, after 3 days, that's wrong. We can do it up to 5 days. So although it makes some of our colleagues in otolaryngology spin their brains, it drives them crazy, I like it because patients can breathe better, feel better, and it helps to, I think, improve the plumbing and the drainage of their noses. If it's an allergy, then treat them for allergies, for goodness sakes. Just make sure they know that the steroids will take weeks to kick in. Some patients will ask for vitamin C. It's fine. If you want to acidify your urine, do it. Does nothing for URI, but it's fine. Appropriate hygiene and infection control. I think in the context of COVID, that's an easier sell. Going home to your family and trying to isolate away for at least a few days to not spread this around, staying home from school. But neti pot, ooh, I love the neti pot. And this is evidence-based, and I think it's something that we can give our patients to do. We'll come back to neti pot in just a minute. Big advance. So, if it's not going to be fluoroquinolones, as we talked about before, because that's against the rules, it's going to be a beta-lactam. And with that in mind, what are we actually going to do? Well, Amox or Amox to the clav, these are the official guidelines from IDSA, 5 to 7 days. I like that. And then if they can't take that, that they could do Doxy or Levo or Moxy. But again, Levo and Moxy, I think that's old news. I think this is incorrect and should be demoted, as we have already done with sulfa and with azithromycin. Those modified IDSA guidelines are well overdue because the new black box warning in quinolones that say don't do this unless you really have no other options on the table, and usually you will. So rhinosinusitis, I love the neti pot. I like this kind of story. Why people swear by it. Saline irrigation may not sound sexy, but Kelly Nance says she's hooked. And look, she's got a baby, and they've got this little fun teapot, and it's just a happy, fun story. It puts the patient in the driver's seat. It gives them something to do. So I love this. It makes me happy. What I do not love is this. This is a patient who died this way in my city of Seattle due to a parasite that we literally did not know was here. If your patients are concerned about global warming being a hoax, just point them to this person who had an amoeba living in our potable water supply, municipal water. She was someone who was doing what she was told by doing neti pot, but she had not cleaned the water. She had not boiled it first. Just boil the water, let it cool, and use that. She didn't do that, and she ended up getting a parasite that ate her brain and killed her. So I love neti pot. It just has to be clean water before people do this, please. It's important. Global warming, it is a thing. Okay, so patients may ask you what's wrong with my immune system. I have to keep coming back and seeing you for these respiratory infections. The answer is easy. You have to quit smoking, right? I want your cilia of the lining of your sinus to look like the wheat. out here by the Columbia Gorge, where it's just the wind comes along and you see these huge flowing leaves of wheat. Yours looks like the floor of a casino in Las Vegas. It's trampled down because you smoke and you're killing it. So you got to quit. But beyond that, probably nothing. Having said so, they might be right. They might be right. So common variable immunodeficiency, it's common, it's variable, it's an immunodeficiency. It's something that we should look for, and screening your patients for CVID, if they have recurrent sinopulmonary infections, sinuses, lungs, ears, send an immunoglobulin panel. You may pick up a diagnosis. And if you don't, you'll do a patient a disservice. We can fix that. We give them immune globulins and we get them better. Having said so, I also worry about cystic fibrosis. And we typically think of CF as a childhood disease. It can be. CF, if I'm not mistaken, the most common genetic or inherited condition in the United States, and that's because it is incredibly variable. The oldest patient who was diagnosed in my practice, age 72, just met that person 2 weeks ago. So it's amazing how often this will be missed over time. Please consider referring to pulmonary. If you have access to testing, that's great, but if not, send them to see an ID doctor, an immunologist, a pulmonologist, and consider saying, hey, could this person actually have an unusual variant of cystic fibrosis? That's all for the treatment side. But I know what you want to do. You want to give antibiotics to prevent this, because why not? I mean, we're told that giving antibiotics for prevention can be helpful. That may be the case in certain cases, but often not so much. I want to talk about COPD again, especially while people are quitting smoking. They may develop chronic obstructive pulmonary disease. We have evidence published in the New England Journal more than 10 years ago that says that patients who take azithromycin versus placebo are less likely to come to hospital with a flare of their COPD. And this has driven a huge hunger, appetite among patients living with COPD. Hey, give me my azithromycin. And in that particular trial, it was beneficial. Then came the European experience, especially in Denmark, with patients who actually were harmed by taking their azithromycin, especially around long QT, cardiac toxicity of this medicine that does have potential cardiac effect. How do we put this together? Well, I like this particular paper from 2015. It's a meta-analysis, more than 1,600 patients. They looked at the weighted risk reduction. In their opinion, patients who took azithro to prevent COPD were less likely to have an exacerbation. The effect is real, but also so too the adverse effect, or AE odds ratio, was substantially, in fact, equally higher. So you're less likely to be hurt by COPD, you're more likely to be hurt by the antibiotic. And so here's what they said. Our results suggest that 6 to 12 months of a macrolide in the United States, azithro, could reduce the frequency of exacerbation, but we have concern for long-term adverse outcome issues, the emergence of resistance. You have to make that individual choice with the particular patient. I think that should always be the way that we practice. Nothing comes for free, in other words. This is no exception. What will trigger an exacerbation of COPD? Bacterial infections? Yes. If someone comes in with more cough, with more difficulty breathing, they may have a bacterial infection. But there's all these other things. I was thinking of it last night, getting off the plane to come here. Such a beautiful city. I love this part of the state. Man, there was a lot of wildfire smoke out there. It was just stunning. And it's that time of year where our patients with chronic asthma or COPD, they'll tell you the air quality is less. I mean, those are our canaries in the coal mine. So thinking about that as a triggering factor, that may be a piece of this as well. How do you put it together? You know, the GOLD stands for Global Outcomes of Lung Disease, the gold standard. And what they've come up in terms of looking for acute bacterial exacerbations of chronic bronchitis, talk to the patients. Are you having more cough, fever, chest pain, dyspnea, more sputum production, more purulence of your sputum? And that if they have any of those last three, that is, in their analysis, a pretty good predictor of which of these patients may in fact benefit from antibiotics. But cough, fever, and chest pain alone, not nearly as much. So GOLD recommendations say give antibiotics if those last three are all there, or if it's purulent sputum plus another. And certainly if they're admitted, you know, that's one of those where you might be over-treating, but the risk of not treating them is just too high. Would we treat COPD with antibiotics? I just want to call to your attention here these antibiotic recommendations. I like the idea of 5 days of amoxicillin, like as if they had community-acquired pneumonia. Same thing. What I do not like is 14 days of doxy. That's old school, and I think that needs to be updated in light of this really, I think, incontrovertible mountain of evidence that less is more. It's not that at the end of 5 days your cat patient is well. It's that at the end of 5 days your cat patient has no more infection. They're still hit by a truck or a train or a forklift, and they'll come up with different vehicles that hit them. They're not well, but the germs are dead. Now they have to convalesce and get better. And I think if we talk with them about this, that may make it easier for them to understand. Do we have any new options for community-acquired pneumonia? Yes, there is this new medication. It's called lafamulin. Lafamulin is a new class, the pleuromutilin class. It's been around for decades. It's only been available FDA approved through a topical formulation called retapamulin or Altabax, which nobody uses because a little tube is $200. But now we actually have it as a pill or an IV, and it costs way more than $200. Why is this an option? It's FDA approved for the treatment of CAP, which is good. So for your patients who cannot get standard CAP treatment, it's something to know is there because of its expense and because, in my own personal experience working with patients who take it a lot of GI issues, the tolerability may not be as good as we'd like it to be. I predict that none of you have probably prescribed this, and it's unlikely that you will in the next year or two. But if you are working with a patient who has a number of legitimate allergies or issues, please know that this drug exists and can be ordered, and it may save their bacon. It looks very effective, even if it's not particularly well tolerated. And the official numbers from the phase 3 trial are listed here. A lot more nausea than 5% in my experience. At a cost of, $200 to $300 a day, it becomes a bit of a barrier, and most formularies through insurance companies don't like to cover it because it is new. We'll skip very quickly through prosthetic joint infections and then allergies. Number one, prosthetic joint infections. No one likes prosthetic joint infections, but we all deal with them because there's more and more prosthetic joints, and there's more and more prosthetic joints because we weigh more as a society. And the map that you see animating is looking at the rate of patients who are overweight, people living with being overweight nationally. We have gained weight so quickly that it's almost something that we take for granted. The reason I raise this is that as we weigh more, we wear down our joints. As we wear down our joints, we need more joint replacements. So it's predicted that we're going to need literally millions more new hips and knees, especially in the coming decades. So this is an issue. And as we do more joints, we see more infections. With these infections, it's a huge problem. And I hope that none of you has had to live with this in your own life or within your family, but once one of these knees or hips gets infected, it is a problem. It is a surgical and medical mess, and you would do anything that you could in your own practice to prevent this from happening. Which leads us to the question of whether we should give these patients antibiotics before they go to the dentist. That's what I'm trying to get to. And the quick answer is we really probably should not do. This has been a sea change in the way that the American Orthopedic Association and the American Dental Association and the ID Society of America have all come together. Just to do the teaching point with you, you can see on the list here a number of risk factors for bacteremia related to the mouth. And to cut to the chase, because time is short, the bottom line is that if pulling a tooth is a relative risk of 1, I think you can see that just random effects without any particular risk factor, what I call daily life, is dramatically, by more than 1,000,000-fold more risky than pulling a tooth. In other words, pulling a tooth is not a thing when it comes to the risk of bacteremia, and even most dental procedures are much less risky, less than daily life. It's not that you won't get an infection with respect to dental procedures, it's just that it's just a super duper uncommon issue. And so, just as we have changed our guidance for endocarditis prophylaxis to be more selective, so too I think we need to with prosthetic joint infections. My patients with prosthetic joints, I tell them, you gotta take care of your mouth. It is such a problem. Gotta quit smoking, yet another reason. And you've got to deal with your periodontal disease, you've got to get with a dentist. Don't worry about going to the dentist. They have heard from their surgeons in some cases, I can't go to the dentist because I might get a joint infection. It's the opposite. You must go to the dentist in order to have healthy mouth and teeth and gums. We no longer recommend this on a routine basis. There are exceptions, but again, the American Dental Association has come out to say exactly this, and the American Orthopedic Association practice statement is the same. So that's a sea change for our society. Once in a while, I'm wrong. I did see this patient. You can see that he broke his mandible when he was biting on a candy cane off the Christmas tree in late February. I am not making this up. And anyway, broke his jaw and then didn't deal with it and ended up with mixed anaerobic infection of his prosthetic knee. It was a problem. So once in a while, Dental Source can do this. please take the Christmas tree down in January. Just don't let it sit there. You will be tempted to eat those stupid candy canes. But generally speaking, that's very rare. If your patient has HIV that's uncontrolled, if they're getting chemotherapy, they've had a transplant, if they're heavily immunosuppressed, and they've also got a prosthetic knee, yeah, you can give them some amoxicillin when they go to the dentist. These should be exceptional cases. And I said amoxicillin because that's how I want to wrap up this session, which is talking about beta-lactam allergies. And I hope this resonates with you as it does with me. Patients often say they're allergic to penicillin. I think they might be wrong. How can I figure this out in the office in my busy practice? There is a 90% chance that you are correct, that your patient is wrong. Usually patients who say they're allergic to penicillin are mistaken. Either it used to be true and it isn't anymore, or it was mythological, or it was their sibling who had it and their parent couldn't remember. It's usually wrong, and that has major implications for you and the choice of antibiotics that you may reach for. So if 10% of Americans, and this is true, roughly 10 or more percent of Americans believe they're allergic to penicillin, only 10% of them are correct. The rest are wrong, and that puts you in a difficult position. Why? When you reach for antibiotics, you want that beta-lactam, penicillin, cephalosporin. They're clean, they're easy to dose. They tend to have better resistance profiles. They tend to have less side effects. You want it to be a beta-lactam, and this potentially takes that off the table. So your mandate, I think, is to figure this out and to adjudicate this. And it makes me scream and hop in mad, and it blows my flippin' lid that in 10% of Americans we're using the wrong drug because we have the wrong data. And that, I think, we can do better. To make this an improved situation, of course, we talk to our patients, get that history. It's what we do professionally as physicians. Find out what's going on, dig deeper. EPIC, it is a 4-letter word, and it will have, whatever EMR you are stuck with, it will have a label, an alert. This person is allergic to this or that. That's because you have an MA who's wonderful, and they may have entered that into the system. Once you get that allergy in the EMR, it's really hard to delabel and get it out, and these tend to become self-fulfilling prophecies. Try to break that cycle. What happened? Do you remember this? When was it? There's a difference between I had nausea and vomiting and my skin fell off and I needed a skin graft for Stevens-Johnson, and of course everything in between. So that's what we're trying to suss out, because the implications are pretty substantial. Here's some, I think, really nice studies, ambulatory care, patients who had antibiotic allergy to penicillin, but it was more than a year ago, it was just a rash or some other benign issue. These patients sat in chairs and watched TV or flipped on their phone, TikTok, whatever they do nowadays, and they got amoxicillin, 250 milligrams PO, and they sat there for 1 hour and were observed. And nobody had anaphylaxis, and 95% of them were fine. A few people barfed, just because they were going to barf, because they didn't have anything with it. On the other hand, if it was a more recent issue, if this was concern for anaphylaxis, if it was really a problem concerning for that type 1 IgE-mediated reaction, they did not get a test dose. They saw the allergist, and the allergist did a skin test, and the reliability of that skin test, what we call pre-pen skin testing, very, very good reliability. And so this could pretty immediately put people in those 2 buckets. Almost everybody was in the top bucket that you see here. So I love this, and when my fellows do it, I give them a shaka sign and a strong sign. I will send them the emojis they can keep in their emoji book from their program director, because I'm really proud of them for doing this. It takes work, but it's huge. And the time to do this is not when they have an infectious disease. This is the problem for primary care. In my opinion, this should become part of the routine standard of care for anyone entering the practice. I'm just going to leave that there. You have so much to do in primary care. Do they have diabetes? Do they smoke? Cancer, vaccines, all this primary preventative stuff. In my opinion, if your patient comes to your practice labeled with a penicillin allergy, please deal with it somehow. Put it on the agenda, because if not, I promise you, they will have a UTI or a sinus infection, and then it's too late. Now you've got to do something. You're going to reach for a quinolone. It's a mess. So I think this is a preventative opportunity. We're excited about this. There's a lot of evidence to show that the majority of these allergies are not only bogus, but can be dealt with in primary care. The problem is that those papers are spread out all over the place. Primary care is incredibly busy. How do we put this together? Well, yep, there's an app for that. We call it Pallergy. It's your pal for the fight against bogus antibiotic allergies. We have built this. It is now in beta form, so you're not yet able to download it onto your phone as an app, but you can go to the website, and you can make this into a web app if you wish. So if you're able to scan that barcode, you're certainly welcome to. We would encourage it. What this will do is allow you to sit with your patient. The mandate is that in 1 minute or less, you ask a series of questions, and then it gives you the recommendation. And the recommendation is going to be pretty straightforward. Either they should see an allergist or not, and either they are safe to get a cephalosporin or not. And it's pretty conservative. We don't want to hurt anybody. So this won't allow you to give everybody a cephalosporin, for example, but it'll allow you to put people into those 2 buckets. And I'm hopeful that it will be acceptable to you. There is a feedback feature that's built into there. If you try it and you like it, let us know. If there are problems, let us know about that as well, please. Yeah, I'm going to skip through this, but basically we move into green light, yellow light, red light. Red light is you're never going to use the beta-lactam. Green light is it's totally fine. Yellow, I'm not sure. They should get in with an allergist. And again, these criteria will be available to you through the online slides. I think they have access to all of my slides through an online portal, if I'm not mistaken. Thanks, Tao. So I would summarize by saying ID is easy. Being a doctor is easy. It's just like riding a bike. Except the bike's on fire, you're on fire, everything's on fire, and you're in hell. It feels like that sometimes, but it's not necessarily. These are the conclusions. Antibiotic use nationwide, tremendous variability. Skin and soft tissue infections. If it's purulent, you're thinking Staph aureus, incise and drain, and maybe give antibiotics. If it's cellulitis, antibiotics alone should do it. Community-acquired pneumonia, 5 days, almost always. And try to do a beta-lactam when you can. Lafamulin, that's out there as a new option for community-acquired pneumonia. It remains expensive, and it may not be as well tolerated by your patients. For COPD, if patients flare, it may not be an infectious disease. Know those gold criteria: purulence of sputum, increasing sputum, and difficulty breathing. Those can be important to look at. Prosthetic joints, if your patients are living with a prosthetic hip or knee, they may ask you for a script for antibiotics. They're going to the dentist. They probably don't need it, and if you do that, you may actually be putting them at increased risk of resistance and antibiotic side effects. Antibiotic allergies are almost always bogus. Test less, talk more. Usually talking to patients will reveal the answer, and if you wish to use our decision support tool, you'd be very welcome to. That's what I had in mind, and I think we may have time for a little bit of Q&A. Thank you. Please.
So I have a question. You were talking about MRSA and the MSSA. If a person has a pustulant wound, just do IND. You said if it was like 5 millimeter?
Centimeters. So the official guidelines and the way FDA does is that if it's a 5 centimeter surrounding redness, assuming that they have a skin tone where you can see the redness and assuming you would measure it, if it's more than 5 centimeters, that's considered criteria to treat with antibiotics in the old rubric. In the new rubric, the thought is maybe all these patients would have some benefit to treatment with antibiotics in addition to the IND.
So the new rules are to treat with antibiotics?
Yeah, they're not rules, they're
guidelines.
It's not even in the guidelines, it's the studies. Now, those studies have not yet come through with respect to the guidelines. The guidelines do not mandate that we do this. Rather, I think it's a little bit more nuanced than that to say, yeah, those patients may benefit from antibiotics. As I showed you, the difference in one group versus the other, placebo or antibiotic, 12% difference. So that's something. It wasn't 1% difference. There was something there. You may still have concern for giving antibiotics because of toxicity or side effects. In those cases, I would feel comfortable not doing it, even for uncomplicated infection. Having said so, I will tell you, a lot of my colleagues have switched so that, yes, they do always give these patients sulfa, for example, or doxy. That's not my practice, but then again, I don't deal with these people up front as much as you might. I wonder what you and others are thinking about that.
So is MRSA and MSSA, are they, the pathogenicity, is it the same?
Yeah, good question. There are certain MRSA strains, especially those that make Panton, Valentine, leukocidin. There's certain MRSA strains that are very avid to the skin. So yes, MSSA can absolutely cause skin infections, but MRSA seems to have a special avidity to skin. It likes the hair follicles and the sweat glands. I don't know exactly why. They're both, having said so, they were both included in those analyses. So that benefit of 12%, I think, was similar between MSSA and MRSA. Both bugs can benefit in some cases from antibiotics. And you'll see that in your practice too, infections with both. please.
I was just curious if you can sinus flush too much?
Is it possible to overdo it with the neti pot? Definitely if the water is not clean. I think I have not yet, that I can recall, come across someone who has overdone it. Having said so, Dr. Smith, James Smith, he's one of our otolaryngologists from OHSU. He'll speak in this conference, I think tomorrow. Please seek out Dr. Smith and get his opinion. In my opinion, the answer is not bloody likely, but let's see what he has to say. Thank you. Good question. Please.
I have a question on upper respiratory infections. What's your opinion of zinc, Zicam, and Cold-EEZE and those things?
What about zinc? So zinc has, like any other divalent cation, we know that, but zinc in particular, it can have disruptive effects on the membranes, the surface of viruses. This has been looked at for a long time. There's a whole long history there. So the data in the benefit of zinc by lozenge or by suspension is pretty clear for diarrheal illnesses, that it helps the gut put itself back together. In respiratory infections, what you're asking about, the data are very mixed. I am actually a big fan of zinc because it gives the patient something to do. They're chewing on something, right? They feel like they're actively working on this. There are some data, if you look at the Cochrane, I think you'll find that it really is fraught, depending on the dose that was used, the formulation that was used. These details probably do matter. So I'm pro-zinc, so long as it is not in the spray. That has become clear. It definitely hurts patients. And in fact, that was University of Washington, Dr. Greg Davis, who found that the Zicam spray could lead to anosmia in those patients. So never to be sprayed in the nose. But for a lozenge in the mouth, I'm not aware of bad side effects. With that, it causes constipation, just like Pepto-Bismol or iron. So you tell them, take your prunes. But I give them that option for a respiratory infection. The benefit at most seems to be 1 or 2 days fewer of symptoms in rhinovirus infection. But you get less symptoms by a day or two, go back to work, go back to school. Yeah, I think favorably about zinc. I would just say some of the subsequent papers have been less clearly favorable. Nevertheless, seems a pretty benign approach. Good question. Yeah, please.
Yeah, I just had a question about C. diff and the treatment guidelines. I missed the first 10 minutes of your talk, so I hope I did.
I didn't talk about C. diff, so it's good.
Okay.
Appreciate it.
All right.
Yeah, so I cut those slides because I knew we were short on time. And as is always the case, I should have just left the slides in because we're going to talk about it anyway. So C. diff, how do we treat it? Number one, you stop the antibiotic that triggered this, as Dr. Lewis said. That is equally important to anything else that you do. We miss this communication, and sometimes you can't. They have endocarditis or TB. Sometimes you have to keep going. But almost always stop the trigger antibiotic. Then number two, kill the C. diff. Killing the C. diff can be accomplished with either oral vancomycin or oral fidaxomicin. Those are the two. We used to use oral metronidazole. That is just not recommended, has never been as good. That's what you give your mother-in-law. You save the vanco for your mom. That's the old joke. So metro not on the label anymore. The question is it going to be oral vanco or oral fidax? The IDSA guidelines prefer fidax over vanco, although they also say in the same sentence, sorry, I don't have the slide here, if you cannot access fidax for, what's the word, Jessica? If there are resource limitations, then you're meant to use vanco. In other words, if you can't spend $1,200 for fidaxomicin, then stick with what's $120. That's why at my hospital, we do not use fidaxomicin first line. We always use vanco. We have the option in our own UW medicine guidelines to use fidax for a recurrence. Why? Fidaxomicin, I think, is a better drug than vanco. I really do. I think it's more narrow spectrum. That's why you have a 15% lower risk of recurrence, because it's letting the other stuff grow back to compete in your gut and get rid of the C. diff. The American Gastroenterological Association, AGA, guidelines, vancomycin is first line, period. In the IDSA guidelines, they've tried to promote fidaxomicin. It has made most of us very cross that they have done that. So I can only tell you, in my experience, it's vanco. Vancomycin first, usually vancomycin second, and then fidaxomicin thereafter. It's a superior drug. If it were free, I would use it every day. It's not, and that has been an issue for some of my patients. Good question. Yes?
I have a specific question about doxycycline. So I work in a multi-specialty group, and our dermatologists routinely recommend 4 to 8 weeks of doxycycline for kids with moderate and severe acne.
Yeah.
And and it works really well. And often we, with a recurrent flare-up, we put them on a course again. Anecdotally, they seem all to tolerate it pretty well, but hearing the lecture today, it just always makes me nervous that these kids aren't allowed the doxycycline time and again. So I was wondering if you can comment on that.
Yeah, the comment is, I've been asked to give a similar talk at the Washington State Derm Association next week, I think, and that's their top question. Because the dermatologists feel nervous. Not only doxy, but minnow. Minocycline is another one that they really like to use at this crazy, they don't even call it minnow, they rebranded it Orencia, it's minnow. It's like a tiny microdose of minnow. It scares the bejesus out of us for the reasons that you have said. It seems like a perfect way to build resistance. All I can say is, number one, it seems to work very well, and I think that's important, right? Because you don't want kids to come in with a true infection. Then they're going to need more antibiotics, so I'm mindful of that. Number two, we just have not seen that rise in resistance over time. And I don't know why. Doxycycline today in Washington State remains a very good option, more than 85% reliability in MRSA infections. So I can't explain why we are not yet seeing an explosion of doxy-resistant MRSA like we are an explosion of Clinda-resistant group A strep. So far, we seem to be getting away with it. But my comment is that I agree with you. It does make me nervous, and that's why I'm eager to meet with this whole derm association next week and see what their thoughts are about it. I do not see that practice changing anytime soon. Please, if you do treat your patients with doxycycline, make sure they cover up from the sun. It is a true photosensitizer, especially people with so-called Caucasian skin. They can really burn, and also make sure that they take it with food so that their esophagus doesn't get cooked. Oh, Dr. Danaretti is here. You are in for such a treat with Dr. Danaretti. I am excited about
I
this.
always want to ask the last question. And you just mentioned about on the COPD treatment part.
Yeah.
And on your slides, you went through quickly. So what is the role of procalcitonin?
Oh, what about how do you decide who's having a COPD flare due to infection versus otherwise? The technology of procalcitonin is available in many settings. Procalcitonin, it's a hormone that has nothing to do with infectious disease. I have no flippant idea why this works, but it does seem to. In the European setting, there's a company called Brahms. Brahms, it's the one company that has a truly validated instrument for this. And I'm raising that for two reasons to get to your question, Tao. Number one, if you're going to order procalcitonin for any infectious disease, forget about COPD. What about someone who's coming in with, I don't know, you think it could be a pneumonia? Is it urosepsis or is it a PE? It's tempting to do. Put them in the bucket, infection bucket or other. Please understand, we have major concerns about the way that most instruments in Washington State are validated and run. And I'm not going to name names because I can't. I literally cannot tell you all the different companies that are doing this. If you are thinking of bringing one of these instruments online in your practice, hospital or otherwise, please do internal validation. And our experience, I'm happy to share, whereas we could not afford the Brahms instrument, we're state funded, so we got some other company, I don't even remember who it was. Without exaggeration, normal saline was better than this. I mean, it was literally a scatter plot. It could not validate. Their shit didn't work, pardon my French. We were very upset about this because we spent a lot of money and a lot of time doing this. That's why at my hospital, we actually do not offer this. However, if you have access to the good stuff, which is made by this company called Brahms, or whoever in the United States licenses their tech, then it can be helpful. So that can be something to consider doing. I like that idea. Most of our experience with working with groups around the state through what we call our UW Tele-Antimicrobial Stewardship Program, or TASP, I think that many hospitals actually do not have access to that particular instrument, and so I would be very skeptical. I'm not clear that a non-Brahms instrument is superior to the gold criteria. And remember those three different criteria. Are they having more cough? Is it more purulent? Is there more quantity of the sputum? To me, that's what I would stick with over the procalcitonin, unless you've got the good instrument. And maybe at the break, we could talk about that. I'd be interested to hear what people's experience with procalcitonin. I had the highest of hopes for Procal. I'm an antibiotic steward. It has not helped in our practice, I'm sorry to say. So sorry.